Grand Rounds, which bears the name of our founding chair, Roy Benke. And I think today's talk is one that a lot of people are going to like. It has really been an incredible run, as we've talked about this year for our outstanding lectures. And today we have Dr. Chris Jackson, who is our new Associate Dean for Student Affairs. Chris just arrived in the fall. Chris is a graduate got his undergraduate degree from Emory University, then headed to the Medical College of Georgia in Augusta, where he grabbed his MD degree and then headed for his internal medicine residency at UT Memphis. Chris was an R13 NIH research scholar during his residency and stayed on in the faculty at UT Memphis, where he quickly ascended the ranks in leadership. He became associate program director, followed by vice chair of education, before transitioning over here to the role of associate dean of student affairs this fall. 2024, we all wish we could have a year like Dr. Chris Jackson had. He was selected for Emory University's 40 under 40 with that high distinction, then received the University Distinguished Alumnus Award from the Medical College of Georgia in Augusta. He also had a year where he published 31 mostly first author, but if not second author, publications, peer-reviewed publications, and in his young career has a total of 75 publications, along with 3 book chapters and numerous posters and presentations. He is also a graduate of the VHA Patient Safety and Quality Improvement Fellowship, of which we were talking earlier of our great pride in that fellowship, as we had one of the earliest fellowships ever in the country here at USF. With that, I'm going to turn it over to Dr. Chris Jackson, who's going to give an outstanding talk today titled Beyond the Exam Room, Scholarship for the Busy Physician. Chris, it is an honor and pleasure to have you here, and let me, on behalf of the Department of Internal Medicine, welcome you to Tampa, and we look forward to hearing this talk. Thank you.
Thank you so much, Dr. Lozama, for a very kind and wonderful introduction, and to all who have taken their busy lunch hour and joined me. I truly am appreciative, and I hope that the talk today inspires a discussion. And that discussion is, how can we meaningfully engage in contributing to the medical literature? And one general point that I want to bring across is that we all have contributions we can make, however small or big we want them to be. So with that, I will share my screen, and if I can get a thumbs up or something to say that people can see my screen, I'll get started.
Looks good.
Excellent. So this is the outline that I hope to get through today, which is some disclosures, a disclaimer, why scholarship, whether in training, outside of training, and then kind of getting more detailed into different types of scholarship projects, and not just starting these projects, but then how to complete them, and some of my own final thoughts. And then I would hope to be able to leave time for questions at the end. Again, I will not profess to be an expert in this, but want to start a discussion. So related to this talk, I have no relevant, financial disclosures to any of the things that I'll present today, but I do have some disclaimers. I do believe that this is a safe space for discussion and inquiry. I do prefer discussion over lecture. Again, my goal is to facilitate the beginnings of a conversation. Part of what I'll be talking about today is from my own work doing editorial things for the 3 publications that are listed there. And I hope I can convince you that scholarship can be fun. I know it can be this very daunting thing, but I have grown to really appreciate scholarship as an expression of just my clinical curiosity. And I particularly think, as generalists, subspecialists, we all have clinical curiosities, and it's really thinking about scholarship as the way to explore those in different ways that has helped me not only find fun in scholarship, but also involve others. So why do it? I think before you can jump into what are the different types of projects, I think you have to at least be able to enumerate some benefits. For those that are residents or in training, it is an ACGME requirement that you're involved in scholarly activity. For my fellow faculty colleagues, I think the ability to be able to contribute to the medical literature and collaborate with colleagues is a wonderful benefit of scholarship. Some of the greatest mentors I have started just from a scholarly project. And then in the academic medicine realm, of course, there's the pathways for promotion that often will involve scholarship or showing evidence that you disseminate your work outside of your institution. Now, that being said, thinking through that, I want us to think about the benefits a little bit more of a high level way. What are those everyday opportunities for scholarship? And then what are the frameworks that can help you complete things? And then again, how do you bring it to completion? So I want to say first, why do I say scholarship instead of research? Okay. So on the left is the depiction of what I thought of doing research scholarship when I first came into medical school and even into residency. Um, like many students aspiring to go to medical school, I spent a summer doing research, figuring out Western blots, etc. And it didn't take but more than a couple of weeks for me to figure out that for me, that was not going to be my journey. While others found it so incredibly exciting, for me, I did not. It just wasn't the thing that clicked for me, and I worried a bit because I was like, gee, if this is the way that you meaningfully contribute to the medical literature, I don't know if I'm going to fit because, again, that doesn't excite me. However, I recognize its importance. Fast forward to in my training, I got introduced to this idea of scholarship that was popularized by Boyer in the 1990s. And the idea was that if you think about scholarship, there's kind of these four different areas of ways that we contribute to the literature that are equally meaningful, but may not be the traditional research that we think of. So research, in the typical way I thought of it, would fit under Boyer's model of discovery that you are advancing knowledge, you are coming up with a new drug, a new protocol for treatment, a new diagnostic tool. And of course, that is very important, but that's not the only way that we can engage with scholarship. There's also integration. How do we synthesize knowledge, whether that's review papers that summarize the findings of multiple papers on a subject? How do we apply knowledge, whether that is, for me, evidence-based critical appraisal? Can I do that through scholarly work? Or the scholarship of teaching in and of itself? How do we best teach skills, whether it's around the auscultation of the heart or whether it is around how to teach students, residents, and others how to do effective critical appraisal? What I hope you gather from this is that whether you fall on the side of research or whether you fall on the side of scholarship, there are multiple opportunities and ways for you to engage with the medical literature. And just because you don't fall into the area of research in the more classical sense of advancing knowledge, doesn't mean that you can't find other meaningful ways to engage. So if I gave you some key takeaways here, research typically we think of as creating or expanding new knowledge. Scholarship I like to think of as kind of sharing, synthesizing, applying knowledge. And not all scholarship will require original research. And then, of course, there are all these different examples, some that we'll cover today, some that I would welcome and love to have a conversation with those about, if they have additional questions or considerations. So that's why, for the rest of this presentation, I'll talk about it from the perspective of scholarship, not necessarily just research. So, okay, if we agree that scholarship is the frame of how we're going to contribute to the medical literature, next is kind of figuring out a little bit more of the why. And I will say, as a mentor and talking to multiple mentees, when they're trying to decide what to do, whether taking an opportunity, working on a project and things, I always will relate them back to mission. Like, why are you wanting to do something? Because for me, as much as I love scholarship, I cannot say that for every hour at night that I have worked on written papers that I have increased my salary or that I have gotten some immediate tangible thing. But what keeps me doing it is this idea that it's tied to something that's important to me, and that's the mission. So, a word about mission statements. For those that are podcast enthusiasts, this is taken from a very popular podcast called Core IM. And in this podcast, they were talking to two senior career clinician educators, Dr. Kimberly Manning at Emory University and Dr. Grace Wong at Harvard Medical School. And they were talking about how they think through opportunities that are presented to them in line with their mission. And one of the things they popularized in this podcast was formulating your personal educational mission statement. And you see it listed here. I want to teach this learner group about this topic so that I can impact this outcome. And when they got opportunities or when they were considering different things to do, this educational mission statement kind of became a North Star. So that they knew that as they were taking on more and more roles and responsibilities, they could say, this fits with my mission, let me continue. This doesn't fit with my mission. Maybe I need to pass on this opportunity. You can do the exact same thing with scholarship. It also should be personal to you. It can change over time. And to me, it gives you the lens to filter opportunities or collaborations through. Because the more you do scholarship, I will argue, the more you're going to find any number of different things that you can decide to do. And so if you don't have some way or litmus test of figuring out what makes sense or what doesn't make sense, you can find yourself quickly overwhelmed with being on multiple projects and not liking any of them because, frankly, they don't align with what is important to you. So when I think about this scholarship mission statement, I like to think of it as what topic or area am I passionate about? And is there a fresh perspective that I can bring to the published work in this area? And in what ways can I write about this topic? Now, you might say, Chris, that is all great and good, but I don't know that. I'm just getting started. Like, how could I even answer that question for you? So I'm going to show you mine, and then we'll work a little bit backwards. So my scholarship mission statement all centers on this. I am passionate about evidence-based medicine, specifically critically appraising randomized controlled trials as well as clinical practice guidelines. And so for me, my mission statement is this. I enjoy writing on how to use EBM frameworks to make sure our application of the best evidence practices to historically excluded patient populations is just as good as for non-historically excluded patient populations. So for me, when I'm deciding what project I'm going to do, can I take on this additional collaboration, et cetera, it all comes back to this central statement and point. So your scholarship mission statement may look entirely different than mine. The point I'm trying to raise is, as you're considering what scholarship you will or won't do, having something like this, I think, can be extraordinarily helpful. Now, some people will say, Chris, that's great. I don't know what my passion area for scholarship is. And I want to introduce you to one of my favorite illustrations that I use with mentees. So the gentleman in the middle of this slide is Dr. Samir Shah. He is a professor of pediatric infectious disease at the University of Cincinnati Medical Center. And he wrote this very interesting editorial called, Finding Your Bagel. And he said in the editorial, imagine if you were walking on a medical campus and you saw someone eating tubs and tubs and tubs and tubs of cream cheese. You would have many questions. I am an internist. Curiosity is part of my DNA, like it is yours. I would have so many questions. Are you okay? Do we need to talk about statin therapy? Do you need to be checked for other things? And why is that? Well, it's that way because typically we don't view, cream cheese as something that somebody would eat tubs and tubs and tubs of. Now, if you saw the same person every day eating a bagel and cream cheese, you would not blink an eye. You would just simply say that person loves, bagel and cream cheese. Why is this important for scholarship? So to me, we can have passion areas. It could be EBM as I like, it could be wellness, it could be a clinical topic focus, diabetes, etc. But if there's not a vehicle by which you explore that passion, it's a bit incomplete. And so when I think through things, like to me, the cream cheese here is what is the clinical, the methodological, the advocacy, whatever topic it is you love to learn and write about. And then the bagel is the vehicle to enjoy that topic. And if you think about it, I think in that way, I think it's a little bit easier to find what is that passion area. And then as I go through the presentation, we can talk about what are the vehicles, or in this case, the manuscript frameworks to explore that. So if you're struggling with that, some other questions that might help you figure it out are, what clinical topics excite me? What issues do I discuss frequently with peers or patients? What's a common clinical challenge that I'd like to explore further? All of these can help you refine what is that scholarly focus that's going to anchor the projects that you do. And I've also included this here to kind of expand on that more, that if those questions I gave on the previous slide are enough, here's some other guiding questions that might be able to help you as you're trying to find that scholarly passion. All right. So we talk scholarship, and then we talk, having a mission with the scholarship that you're going to engage in. Now, what about the actual projects? Like, what are the opportunities? Now, when I talked with my residents at my previous place, I would get one of these two responses when I start talking about identifying projects. You might be like my lovely friend, the dog there, and just are so elated, excited, can't wait to write the next paper. Or you could be like Angry Cat here on the right. There is no judgment if you're on the left side or on the right side. I just hope in whatever way, if you are here, Angry Cat, I hope maybe I can move you just a little bit more to the middle. So deciding on a project. I think many of us have trained and have seen this very similar evidence pyramid that starts with background information, expert opinion, and goes all the way up to systematic review. And we can talk about the merits of whether or not like this is an appropriate pyramid or not, because it's predicated on how well each of these individual things are done. So a randomized control trial that is done poorly, I don't think necessarily is that much better than a well-done cohort study, but that can be a debate for another time. When I say deciding on a project here, I think one unfortunate part of this pyramid is it makes people think that unless you're up here doing systematic review or evidence syntheses, that these things here below don't matter. And I want to dispel that. With scholarship, again, if it's mission aligned and you are doing good work, it is absolutely okay to go for the low hanging fruit. Again, the point is in what you do to do it well, whether it's small or whether it's big. And so I do like to kind of think of what is low effort, what is, high effort. And so I've put this here to kind of just give some different options from a scholarship perspective of what is low effort in terms of time investment and things, what is high effort. And hopefully over your journey with scholarship, you kind of get a mixture of both. And we'll talk about that a little bit more at the end. No matter which pathway you take, I think it's important that as you're engaging in endeavors that are research scholarship, recognize that multiple products can come from that. And so I always give the caveat of, if you start with an abstract and it gets the poster, take it to the publication. If you're doing a morning report and you've done a deep dive on the literature, I promise you, you've probably already done enough to do a review article. Now, again, that doesn't mean that these things are easy to write or do, but again, it's thinking through at the very beginning, like, what are the tangible things from whatever scholarship endeavor I'm going to get involved in that I can then take once I get to the end of it all. So let's start. Letters to the editor, kind of on that initial rung. These are, short one-page manuscripts, usually about a specific journal article, usually can raise new perspectives or point out issues with a reference article. I like to think of these as EBM Journal Club in action. Like, I am a trial nerd. I love reading a good new trial. I love thinking through, does this paper make sense or not? And how does it connect to the larger literature? For trainees and things, I think it's an excellent way to obtain mentorship. Most letters to the editor are somewhere between 175 to 350 words. At the higher end, maybe 500 words. And again, you can do them pretty quickly if you have a good formula and format. So I want to give an example, and I'm going to break this example down in a slide here or so. So uh, probably a couple of years into my faculty role at UT HSC, I was reviewing a paper. And this paper was about the primary spontaneous pneumothorax trial. And in this trial, they concluded that conservative management of large primary spontaneous pneumothoraces were non-inferior to interventional therapy. Now, I'll be honest, there was a point in time in my life I thought I was going to be pulmonary critical care, and so this paper was very interesting to me from that standpoint. The other reason it was interesting to me was I was a little bit skeptical of this result. Um, if the pneumothorax is big enough that I can see it on the image, I feel like that you probably need to intervene on it and not just let it sit there and hope it doesn't pop. So I was looking at this paper and I was saying, gee, this just really doesn't make sense to me. Like I can't, I don't, something about this I can't shake. So I do what we all do. I go and I read the paper and I look at the smoking history part of table one. And you'll look and very quickly see there are some stark differences, particularly in the history of current smoking and in the history of never smoking. Now, if you just do a little bit more research, you'll note that smoking status, both current and if you've ever smoked, actually increases the likelihood of complications from primary spontaneous pneumothoraces. And so as I started thinking about that more, I was talking with a colleague about it who was pulmonary critical care doc, and he was like, no, Chris, you're absolutely right. He was like, that would definitely impact the results. So we wrote a letter to the editor. It was about 175 words, and they took it. Um, Using a very simple formula to lay out what we were concerned about and what the issue was. So let's talk through that formula. The formula was we had a sentence or so that summarized the main findings of the paper. We stated our area of concern or of intrigue. We gave supporting data from the paper and from our research. And then we asked the authors what impact it had on their conclusions. And on the left side here, I have a QR code that if you go to it, whether now or with the slides afterwards, it'll take you to a paper that says how to write a letter to the editor. But I know it can be simple to tell you that formula, but let's actually see how it's used. So in red, I've highlighted our first sentence here that says this was the main finding of the paper. In blue, I've put here what our area of interest, intrigue, concern was. In gold, I've kind of highlighted what the previous literature has said about recurrence risk with smoking in the patients with pneumothorax, and I've also included data from the paper. And then in green, we asked the authors what what they thought the impact was on this. And the authors did respond back and actually told us, oh, you bring up a great point. We did some subsequent analyses and it didn't end up changing the results. But you can use that exact same formula, whether it's any JM, annals, et cetera, to write letters to the editor. You can publish these anywhere, even the heavy hitters. Sometimes subspecialty journals can be a little bit easier to gain acceptance, but it was one of my first forays into scholarship that I found just, again, fun. And it's a great way for those of us who are in the position to mentor trainees to get them involved as well. Another one, editorials. So taking a bit of a step up from letters to the editor, these are going to be short 1 to 2 page manuscripts, either on a published article or an opinion on an emerging issue. Letters to the editor are very, very succinct. These can be a bit more broad, and often they're going to be written by the editorial team for a journal. So that goes to how do you get editorials? I would say one of the best things that have helped me as a writer and doing scholarship is to be a journal reviewer, seeing how other people write and giving thoughts on how that writing can be improved can definitely, improve your ability to be able to write and do scholarship. And I offered to write editorials for the articles I reviewed. Why? Because from the journal editor's perspective, I'd already seen this article. I had given, feedback to the author. So, you're in a prime position to opine about what is there. And you can find a subject matter expert that you trust to review your work. And while they will never tell you this, more often than not, when you're invited to write an editorial for something, it will get accepted. Now, will your first draft be accepted? Possibly not. You might need to make some changes based off of your communication with the editor, but more often than not, it will be accepted. And this was one of my experiences doing it. I was a new faculty member, and I got a chance to review this paper on resident perceptions of competency and comfort before and after telemedicine ICU implementation. And for me, it was a fascinating paper. I remember reading it and saying, goodness, I don't know if I would have felt comfortable with telemedicine ICU. And, they invited me to kind of opine about that and what I thought that meant from a medical education standpoint. And so, again, I would not shy away from, those sorts of opportunities. So, what is the editorial formula? You have to have 1 to 2 primary themes. Usually, the themes will center on if it's a paper, this is the current paper, and this is the next steps that are not addressed in this paper. If it's an opinion on an emerging issue, this is where we are with this issue now, and these are unanswered questions for this issue going forward. You want to use some statistics to emphasize why the reader should care, keep the writing simple and clear, and consult early and often with the subject matter expert. So how does this formula work? Um, this was a editorial we did on a paper called the CLEAR trial. And the CLEAR trial was a paper looking at the use of bempedoic acid in patients that had statin intolerance and whether or not it would improve outcomes, mostly in a population of patients using it for primary prevention, although there were some patients with secondary prevention. So when we structured this, we started with why the reader should care. And if you read through that, you'll see we mentioned things like it's the leading cause of morbidity and mortality. This is the impact of it in terms of the prevalence of things. What's the area of interest here? It was, statin intolerance and its management so far. Then we went to what did the CLEAR trial show? And then what questions still remain unanswered after the CLEAR trial? Again, a very simple formula, but used well, you can again write multiple editorials with that same thought in mind. For my residents, I just wanted to put out there are certain journals where it's very easy for you to become a peer reviewer. I've listed some here. I had the privilege for a year to be the president of the Southern Medical Association, where Southern Medical Journal is. So that's why the smiley face is by that one. They are always looking for new people to review articles. But again, when you sign up at these places and you're reviewing articles for them, again, maybe once or twice, put a feeler out there about whether or not they would take an editorial from you. One of my favorite phrases from residency, we should write this up. And often when I heard this, it often centered around clinical vignettes, case reports. I won't spend too much time here because I think a lot of us, at least have thought about or done case reports. I do want to emphasize one thing, though, from this slide. And the one thing is that we typically think of clinical vignettes as case reports as being that first point that we're looking for a new or rare diagnosis. I will say, though, that's probably the hardest the hardest benchmark to hit. The other four reasons listed there are also fine reasons to do a clinical vignette or case report. And so I would say I would be careful with the idea that only a new or rare thing is case report worthy if you have something in your case that you're talking about that can fit into any one of these other four options. So I would consider that when you're thinking through, should I or should I not write this case up? Highlighting some of examples from my former institution, you see kind of two different examples here. One of something that was very rare, and then one of something that's not necessarily rare. People have myelodysplastic syndrome, but they decide to focus on unique aspect of complications involved in a patient that, in this case, had paraneoplastic autoimmune vasculitis. The illustration I'm trying to get at here is, again, case reports can have multiple different phenotypes, not just it has to be new or rare. So when you're considering it, you got to make the correct diagnosis for my residents, students that are on. When your attendings are saying a case is unique, that is, should raise a flag in the mind of, I want to go and look that up more. If you're curious and just want to try to figure out, is this worth diving into more? A quick PubMed search can help you. And if there's less than 10 published reports, I'd argue it's probably worth writing up. If there are more than 10 published reports, again, the question you have to ask is what will be new or added by what you are going to bring with your case that is different from what is already there? And then you want to have 2 to 3 teaching points for the case. Like, what are the 2 to 3 points that someone, after they leave this case, should be able to leave and say, now, as I go to take care of people in the hospital, I could do this, or take care of people in the clinic, wherever the location of care is. So the case report, clinical vignette, always want to obtain patient consent. You can get generic consent forms offline. Some journals will have it. I like to gather all the events of the case, admission to discharge, first patient visit in the outpatient setting to the one where the diagnosis was made. Again, what are those key points? Because the key points are going to help drive your discussion, and they're also going to help drive the things you're going to need to include in your case description. And then you write it in sections. For me personally, I love starting with the case description first. That's the closest thing to me to doing an H&P. And then from there, I go to the discussion next, and I actually finish with the intro because I feel once I have the case frame from a discussion standpoint or a description standpoint, and then I've encapsulated the discussion well, it's easy for me to write the intro that's going to give the reader the lead in to where I want them to go. Where can I publish it? Tons of places. Journal of Internal Medicine accepts some BMJ case reports, American Journal of Medicine. I'll also put out there the Annals of Internal Medicine Clinical Cases, which is a newer journal from Annals. They also take case reports as well. So again, you have lots and lots of options. And the QR code will take you to something that says where are all the places I can publish my case report. Now, this comes up sometimes. What if a journal doesn't publish case reports? I'll use Southern Medical Journal, for example. If you go under instructions for authors at Southern Medical Journal, it will very quickly say, we do not accept or publish case reports. However, they might publish something similar. So in the case of Southern Medical Journal, they publish something called a multidisciplinary clinical case study. If you read them, they are case reports. They are just formatted a little differently to be written from the perspective of multiple specialties involved in a case. Journal of Hospital Medicine, which is JHM, they also will write they do not publish case reports. But they publish these things called clinical case conundrums. We've all had these on the wards and in the clinic. Of course, Journal of Hospital Medicine is hospital medicine focused, so it'll be the wards of cases that, have challenged our diagnostic and therapeutic reasoning. And again, format in the right way, even though it's not a case report, again, it's case report adjacent. JAMA Internal Medicine does something called a teachable moment, where from a case where there was a concern that an additional diagnostic or therapeutic step was taken that was not necessary and was not high value care, you can write about that. Again, they're not case reports, but they're very similar. Next one that I didn't know of, at least in training, but came out more when I was out of training, was actually clinical images. So clinical images are these image-driven cases with 1 to 2 learning points. I actually prefer them over case reports if you have like a really stark, radiology image, a really unique physical exam finding, or if it's a path image, some striking histopathology. And they can be really quick to develop. They're usually between 300 to 500 words. And so I'll give an example as one of my favorite ones with one of my former residents who's now in dermatology practice. We had a patient come into the clinic, and one of the reasons I love the clinic is you don't know what will walk through the door. And the patient came in and said, "My mouth hurts." And we were like, "Why does your mouth hurt?" And we looked in his mouth and we saw this. And the resident looked at me and asked, "Dr. Jackson, what is this?" And I said that this is a GOK, God only knows. I've never seen this, not sure what it is, but hey, let's look it up and find out. And when we looked it up, of course, I knew that there's things on the roof of the soft palate, torus palatini, that you can get. But this pictured here is actually something called torus mandibularis. Very similar to torus palatini, but again, at a different area. And it's quite rare in comparison to torus palatini. And so the resident, she was interested in derm, got very excited. She was like, "Can we write something up about it?" I said, "Absolutely." So we wrote this little manuscript, how the patient came to clinic, how he made the diagnosis, and what the treatment was. And that was the publication of it. Uh, Again, this walked right into the clinic door. Um, and it's one of the reasons I like clinical images because, again, this was us taking our curiosity. We found something that was interesting, and then we wrote about it with the idea that maybe someone else is like us and did not know what torus mandibularis was, but now reading this, hopefully they will know and can take care of their patient, hopefully, and do well for them the way we try to do for our patient as well. So if you're going to write a clinical image, you absolutely have to get signed consent from the patient. While I would say it can sometimes be optional with case reports, usually not optional with clinical images. You have to take multiple pictures because you are going to have to make a determination of which one is the best fit to show what you're looking for. It is very important that with whatever text you supply and the image, that the diagnosis can be made just with that. That is the power of a clinical image, is that it's basically helping a reader build that pattern recognition. So you want to make sure that, again, the diagnosis can be made with the image and with the text you supplied. And of course, pay attention to the formatting requirements for the journal. A lot of places publish clinical images. Places that I have personally have had success have been the Journal of Family Practice, Mayo Clinic Proceedings. You'll see them in New England Journal of Medicine. Even Annals of Internal Medicine has published clinical images before as well. So all of those are kind of in that low time investment kind of space. Now moving to some things that I would argue are kind of medium time investment. And I will give my bias. This is my favorite. I love clinical evidence synthesis. So clinical evidence syntheses, are book reports of recently published guidelines or literature. They're often, you do have to write a request to journal editors to gauge the interest. Places where this is pretty popular would be the Journal of Hospital Medicine with their clinical guideline highlights, clinical progress notes. The Southern Medical Journal also has a section for doing guideline appraisals as well. And again, this is a medium, sort of time investment. And what are you doing with them? So with guideline appraisals, uh, I was talking to my residents and saying, as a second year, I would always ask my attending, why did we do decision X or Y or Z? And the attending would say, well, we're, following best practice guidance or guidelines. And I would be like, okay, great. Why did we follow that guideline? How do we know it's a good guideline? And my attendings, again, taking all my questions seriously and things, said, oh, these are great, Chris. You just need to go and read the guidelines. And then I would go and read and look at these guidelines, and they were 80 pages. And I said, now, there's no way people are reading 80-page guidelines when they have 15, 20 people on a patient list. Just like not possible. Um, then I found these evidence syntheses where, we were taking big guidelines and now breaking it down into 2 to 3 page manuscripts, kind of pulling out what were the key things that a hospital, if it's a Journal of Hospital Medicine, needs to know, if it's outpatient internal medicine, JAMA has a clinical guideline synopsis series. Like, what are the key things they need to know in terms of what was the strength of the recommendation, certainty of evidence, how did they come to that? And then some appraisal of, is this a good guideline or not, or what questions are not answered by these guidelines? Again, I think the one that I've had the most experience with has been Journal of Hospital Medicine. I have it listed here, and I have some wonderful mentees who have been on projects with me like this. But it's really a great way, again, to do EBM in action. Now, with writing evidence syntheses, and you do want to check with journal regarding pre-submission inquiry. Usually for me, that is going to look like 5 to 6 sentences of, hey, we would like to write a guideline appraisal synopsis on this particular guideline. We think the readership would find these 2 to 3 points, interesting. Please let us know, if you're interested in a manuscript on this. And they can say yes, and now you're in and you can go for it. Or if they say no, that's okay. You haven't, already started the manuscript and now have nowhere to send it. Once you do that, then I recommend you kind of read through the guideline 1 to 2 times for understanding. With the goal being, when I do an evidence synthesis, I need to be able to say, I know what the main reason for the guideline being made is. How do I know it is or is not a good guideline? How did they come to their evidence conclusions? And again, what are the things that practicing clinicians need to know? And that goes to the third point, picking those 4 to 5 points with the most evidence backing them, whether that is to do something or not to do something. And then each journal will have their own unique style that you have to navigate around. All right, rounding the corner here, I know that there are tons of other types of scholarly projects. I just wanted to give a sampling of a few. I did want to talk about, how do you finish scholarship with intention? Because it's easy to start, but again, the goal is getting to the end. I always said, where's the paper? For me, I want that at the end. So I want to take you back to my childhood. I grew up in Augusta, Georgia, with 2 wonderful grandparents born in the 20s. And this was a common scenario from my childhood on Sundays, where we would go to church in the morning and we would go to buffets in the afternoon. And so for me, as a kid, what could not be better than the buffet? There are multiple options I could sample from. I could eat to my heart's content, etc. You might say, Chris, great, you're making me hungry, but what does this have to do with scholarship? And my answer is that, similar to the buffet analogy, when thinking about scholarship and completing projects with intention and things, I always say it's important to sample multiple modalities. Not all your work has to be one scholarly type. I've done letters, I've done editorials, I've done clinical guidelines, synopses, I've done meta-analysis. Like, I've done a few different types of ones. And then as you do each of these different scholarly types, you can then determine which type of articles you enjoy writing the best. And both for yourself, and then if you're mentoring people, I like to switch among article types as you embark on different projects because, again, you're trying to show a portfolio that is expansive, that you can do multiple things. One of my favorite papers kind of on this very point is written by Dr. Juan Lessing, who's at University of Colorado, is associate professor, Division of Hospital Medicine, talking about getting the maximum juice from each squeeze. And he talks about how to reuse and recycle different sorts of projects to get multiple things. So again, don't be afraid to sample multiple modalities. You know, you might have initial challenges in terms of doing them, but the more you do it, I would argue the easier it gets. Plan ahead. I always have a short list of 3 journals to submit a paper to. The reality is when you submit a paper, there is 8 to 12 weeks before you will get the first decision. So what you don't want is waiting 8 to 12 weeks and then at the very end, not being able to have anything to show for it. So for me, I always have a list of 3 journals so that if they come back in 8 weeks and say, sorry, we don't want to proceed forward, or, sorry, we just don't think it's a good fit, no problem. I go to the next one. Now you might say, well, how am I going to do that? I've put a link here to a website. It's called janebiosemantics.org. And Jane stands for Journal Author Name Estimator. You can put in the title of your project, or you can put in the abstract. And when you hit enter, it will give you different journals that have published similar things. So for me, having that is helpful because it takes away some of the activation energy to keep going with the project when sometimes we hit roadblocks. And I also try to submit more than one thing at a time, which can feel daunting at first, but because you don't know that every single project you're going to do is going to come back at first with like it is accepted or not, the last thing you want is to have all your eggs proverbially in one basket, and then now you're trying to play catch up. So I try to submit more than one thing at a time. I usually don't go above 3 because then it gets hard to remember where things are. Mentorship is very, very important, very powerful to me. I always say involve mentees early and often. These are some of my most productive mentees, both in their professional endeavors, but also from a scholarly perspective. And so if you want to write a lot from a scholarship perspective, you need to team up and get with others. I can tell you, at least with one of the mentees that is on this particular page, there's probably 12 scholarship projects, that have been there. And so if you're mentoring in scholarship, there's so many different ways, obviously, that you can find mentees. My advice is offer short, achievable projects to get them involved. I kind of have a step approach of, I might start with something like a letter to the editor, then an editorial, then a case report, then a clinical guideline synopsis. And with each thing, at first you're going to be giving a lot of guidance. And then as you get further and further on, you're providing, I think, a little bit less and just more oversight. Um, help them with everything from writing to submission. I've had mentees where we have set up a Zoom or Teams call and they are sharing their screen and we're walking through each phase of making sure when they hit submit, it's correct. Because again, if people are just getting involved in scholarship, you want to give that at first because, when something is new and there's that discomfort, people need that reassurance. And then once they have that reassurance, it gets easier the more they do it. I'll end with kind of some key steps from Charlie Ray et al. Charlie Ray is a health services researcher at the University of California, San Francisco, and he wrote this article about basically completing mentorship projects. And I take a lot of kind of my approach from him of finding the formula, having a mentor, acting, getting an accountability buddy, and carving out dedicated time. Some of these I've touched on a lot already, so I'll skip over. But with, obtaining a mentor, I do want to highlight that here prestige does not matter, results do. And even near peer mentors can be incredibly helpful. For those that are, building that mentorship team, I also want to assure you that a research mentor does not have to be a career mentor. I have people that I've gone to just to help me as I'm navigating certain scholarly projects, and I have others that I go to for career advice. I also want to highlight the importance of acting. I always tell mentees the hardest thing to edit is a blank page. So put something down. It might be the worst thing you've ever written, but if it's down, it's always easier to revise than it is to create. And if you have a mentor, you never want to come empty-handed. Bring something because then, again, it can be worked with, it can be used in some way. Accountability buddy. I'm a big believer that peer pressure can promote self-improvement, and you're much more likely to get to the goal if you have that. And scholarly activity is a team sport. Just like I tend to like to eat with groups of people, I like to bring different groups of people together for scholarly activity too. And then carve out time. There's nothing magical about writing a manuscript. And as much as I love scholarship, I'm not going to tell you every single day, I'm like, yes, I want to spend 2 hours, addressing reviewer number two's comments. Sometimes it's 20 to 30 minutes of work. And just like I would schedule anything else, sometimes I put it on the schedule and say, like, okay, this is my appointment from this time to work on the manuscript, whether that's editing the introduction, fixing some reference issues, addressing part of the reviewer comments. But carving out time is incredibly important. And then never say never. This paper will live in infamy for me because it was the longest scholarship project that I've ever had. It took 2 years. And I'll never forget getting one of the reviews back where they said in so many words they couldn't understand why I would even put this paper out there. And that is putting it nicely, what they put in the review comments to me. But as I was looking at that very critical review and I was talking to one of my research mentors, I was just like, I just don't think I can do this. And he told me something that sticks with me to this day. He said, Chris, every paper has a home. We just have to figure out where it is. And so I've used that to say, I'm going to keep pushing on my projects until I've exhausted all possible opportunities for the home that I think it should have. And for those that are in that process of revise and resubmit, again, this took 8 cycles before I got its final home. Some final thoughts. Just choose one small achievable project. Letter to the editor, case report, clinical image. Identify that mentor accountability partner, and then set aside 30 minutes per week for writing. Again, this is just getting started, and you can always build from there. Remember, small steps can lead to long-term scholarly success. If you're trying to figure out where can you publish, here's some good general guidance. I will say align the journal selection with your career and with your scholarly goals. Here's another way to look at it a bit more expanded. And then finally, I hope I've convinced you that participating in scholarly activity can have multiple benefits. Opportunities for scholarly activity abound. You just need to keep your eyes open. It is okay to go for the low-hanging fruit. And remember to find the formula, obtain a mentor, take action, get an accountability buddy, and carve out time. And with that, I really appreciate you all spending time with me, talking a little bit about scholarship. I'll be happy to answer any questions that you have. And again, thank you so much for your time.
Thank you, Chris. That was just an amazing, inspirational talk. I can't thank you enough for putting this together, and your delivery was spot on. We are just absolutely blessed to have you here at USF Health and really excited about our future collaborations with you. We have a lot of great comments already in the chat, including from our chair, Mark Mosley, who absolutely he and I were as well discussing the importance of all the things you have in just some short texts as we were marveling at your work. I want to open it up to some questions to the audience, and then we'll go through the chat as well. But please raise your hand if you want to ask a question or make a comment for Chris. Dr. Mosley.
Chris, I just want to emphasize my comments in the chat. What a great talk. What an important reminder. I really love your really pragmatic tips about lowering the bar. What I've often heard from trainees, or even made the same excuses myself, is that, there's just not time, or I need to sit down for hours and hours on end. I really love that idea of scheduling and making discrete times. That is really effective. So thanks for those reminders. And again, a great talk.
Thank you so much, Dr. Mosley. I appreciate that. Thank you.
And you're absolutely right, Chris, that the most common statement I've ever heard is, we need to write this up. So if you had a dollar for every time we heard that in our career, we'd have a very nice investment to fall back on.
I see a question in the chat about predatory journals and how to recognize, how to avoid role of mentor in choosing a journal. What an excellent question. For me, predatory journals definitely have been part of my career. Kind of one way I think through it is often I will get an invitation for something that is completely outside of my scope, and that, sometimes is a clue for me. So an example I got one time was a journal that was asking about something in pediatric orthopedics, said, "We welcome your magnanimous manuscript on this thing." And for me, obviously there's no way they could have looked me up and thought, that I would have anything to opine about pediatric orthopedics. So I would say if there's a misalignment between, again, your expertise and what the journal's asking, that's one. Oftentimes these emails will also have spelling errors or kind of weird phrasing of like recommendations. They'll also kind of create a sense of urgency that doesn't exist. They'll say like, "Oh, we need it back in 2 weeks." And when I've been invited to do things for other journals, usually you decide a timeline. And then the role of the mentor in choosing the journal, I definitely believe with the first projects, I like being the one to choose and say, here are a couple of options. And then as the mentee kind of sees how I make those choices, then when they start to bring more projects to me, then I say, okay, you tell me, what journals were you kind of looking at? And we kind of aim for the stars and then keep going down from there. So I will always ask my mentee to try to shoot for the highest one first and then keep going from there. So those are a few thoughts I have, Dr. Flynn.
Excellent. Yeah, some great comments in the chat for folks to read from Dr. Gupta as well, with a plug for our Emerge, which will get the closing grand rounds this year again. So thank you, Dr. Gupta, for all your work there, and from Dr. Mai on the great work Dr. Aller has done on Letter to the Editor workshop. So a lot of good things happening here, and we look forward to a lot of collaboration with you, Chris, to keep things moving.
Dr. Menezes?
Yeah, I just wanted to thank Chris for an amazing talk. And I think what I liked most was what you said at the start was having your own personalized mission. And that helps you carve that niche for what you are going to write. So I think that's such a key thing for each of us to have, to be able to then make an impact in that particular area. Thank you.
Thank you so much, Dr. Menezes, for the comment. Thank you.
All right. I think with that, we will say thank you again to Dr. Chris Jackson for inspirational, wonderful talk. We look forward to seeing Dr. Jackson very often with our Department of Internal Medicine in his role as Associate Dean of Student Affairs. As we mentioned, welcome Chris back, or welcome Chris to Tampa. As, I know it's only been a short time in your role, And we look forward to just wonderful collaborations with you, as I mentioned. Thank you for everyone for attending Grand Rounds. This is a very important conference, and really appreciate the prioritization of this, as it brings a lot of community and importance on scholarship and research and education to things we do here. So I'll let you guys go. Have a great rest of your Thursday, and we'll see you here back next week. Take care.